Good afternoon. My name is David Potenziani. I am the host for the Health Informatics Seminar Series this year, at least until they tell me I can't do it anymore. This is the first time we've done this from UNC, and we, over the summer, made some changes to the approach and format. One of them is that what we would like is for people, when we come to a Q&A portion of our seminar today, turn your microphone on, raise your hand, go ahead and ask your question live. If you prefer to use the chat function in Zoom, feel free. That is perfectly fine. And what I will do is monitor the chat and to make sure that we don't leave any question unasked. Answering it, that's somebody else's problem. Okay. Well, having been involved in informatics and healthcare for 30 years, off and on, what I've discovered, it is among the most complex fields in human endeavor. And one of those complexities is the actual miracle of treatment itself, which isn't just the science involved, the clinician, but it also involves the patient deciding to accept a treatment. And so this brings out all kinds of issues in terms of knowledge and culture, belief, and values. And one of the challenges is for the person providing clinical care to understand and respect what that patient is going. Today, Dr. Amy Cole is going to talk about patients, older patients with cancer, and she has developed a number of approaches to be able to help this process take place where people are advantaged in the ways they want to be in order toward appropriate treatment to be discussed, decided upon, and delivered. So she is a triple Tar Heel, a graduate with her PhD that she earned in the Carolina Health Informatics program. As an academic and a teacher for a long time, you sometimes think that all you are is a traffic cop and you see Chevys and Fords going down the street. Well, once in a while, you get to see a Mercedes. Amy Cole was a Ferrari. So, she has done research into very complex interactions between clinicians and patients, between information systems, and all of the above. And today she is going to talk about her approach called voice. Dr. Cole.
Thank you very much, Dr. Potenziani. Have never been referred to as a Ferrari before, so I'm going to keep that one in my backlog and certainly let my family know about that one. It's an honor today to be able to present at the Health Informatics Seminar. This was one of my favorite courses that I took during my master's program in CHIP, mostly because I had an opportunity to learn about other people's research. And it opened up my world to a lot of different places of how health informatics can actually be applied. So again, my name is Amy Cole. I'm a researcher here at UNC. Today I want to talk to you about the research that I have been recently working on. So it's related to digital health tools for complex treatment decision-making in geriatric oncology. So I'm going to talk to you today about the approaches that I took for aligning treatment decisions with patient values. Just real quickly, we're going to go through, actually my clicker's not working, but well, actually nothing's. Okay. There we go. Real quickly, I'm going to go through the background of why older adults and why it is that treatment decision-making is so complex for these individuals. I'm going to spend a fair amount of time talking about the methods. And the reason why I want to do that is because I want to give you a good grounded idea of what we needed to do in order to assess patients' values. And then I'm going to mix together my results and discussion, and then eventually conclude it with where we're going with this research. Every year in the United States, 1.8 million individuals will be diagnosed with cancer. Older adults, or those who are 60 years of age and older, represent 75% of those, even though they only represent 25% of the population. And for these older adults, they're 3 times more likely to end up with a cancer diagnosis than those just 10 to 20 years younger. There's complexity in treatment decision-making. The good news is that in the past decades, there's been a substantial increase in the number of treatment options that are available to treat varying types of cancer. This means that the potential for increased overall survival is going up. There's a potential that quality of life could go up. But just because we increase somebody's longevity does not necessarily mean that we're increasing their quality of life. So clinicians face this clinical equipoise between recommending different treatment options to these patients. We know from evidence that these decisions are preference sensitive. So it seems like if they're preference sensitive, why am I even here? We just ask the patient, right? Talk to them. This seems to be a little bit more complex than that. And a lot of evidence shows that there is discordance between patients and clinicians when it comes to treatment decisions. In fact, over 50% of older adults face these different types of discordance, whether or not it's the discordance with treatment decision, how they approach symptom management, even discordance over what the expected life expectancy is when they're diagnosed. And so we know that there's a need to improve values elicitation and clarification among this patient population. And we know that decision support tools can actually play a part in this. In fact, we've done a lot of research in developing different types of decision support tools that can help patients think about, self-reflect, and really think clearly about what it is that they value most. And that's great, right? We can hand somebody a tool, help them think about it. But what actually happens after that? Does it actually lead into a conversation with their clinician about what they value most? And so what I really wanted to look at is how can we prepare these patients to have these types of conversations when we know that incorporating their values into the decision-making process can lead to improvements in their quality of life. And so I took an approach and looked at, well, in other research, we see that when we tailor health information to patients, we can actually achieve different behaviors, right? And so oftentimes we think about tailoring information to prevent certain types of activities, like preventing smoking or preventing drug abuse. But in this case, I was looking at how do we actually adjust behaviors so we can prepare patients to have these values-based conversations. Right, so when we tailor information, what we are doing is actually giving information back to the patient about the things that are most important to them. And so I look at, again, these 3 things that I highlighted before. So how does this actually address patient-clinician discordance? Well, there's evidence that supports when you give feedback to a patient regarding something that's important to them, we can actually improve values congruence. Okay? There's also evidence that says when you provide feedback to somebody, it helps them self-reflect, right? And it helps them perform an action. So again, the action that I'm hoping to achieve is that they would actually go into that consultation prepared to have a conversation about what they value most. And then using decision support tools is the medium, because with a digital health tool, we now can elicit the information from that patient and automatically or real time give them feedback, right? We can build the algorithms, we can do the stuff that we need to do to give them the feedback that we want to. And so I took these different principles and looked at, well, how can we actually integrate that into this process? So we developed Voice. Voice is a values clarification tool that elicits and prioritizes patient values and then presents them with tailored feedback based on the information that we elicited. Now, my research is grounded in patient engagement, and so I developed or established a patient and clinician advisory board to actually develop the content that would go into this tool. I'm not going to go into the details of all of that. I'm happy to answer any questions about that if you're interested. But we use this advisory board to, as research partners rather than research participants, and ask them to think about what should be included within this tool. Right, to give you just a brief overview, and this is just a simplified version of what this tool looks like, but basically what they came up with was the content that would be utilized within the survey, where we're now asking patients, well, what types of things do you actually value most when you're making a treatment decision? So they could go through a series of questions and think about what's most important to them and what's least important to them. It's referred to as a best score scaling survey. Again, I'm happy to go into that later if you have questions about that type of survey. But basically what we did is we, again, use that patient advisory board to establish the content that would go into that survey. And then we use that advisory board again to provide the content that would then be tailored back to that patient. Again, this is just a simplified version. There's actually more details that go into this report. But there's 3 things that I want you to remember about this particular report. It is very important because it's based on the things that we'll later look at. The things that we were tailoring to them were their prioritized values. But the tailoring that we were also doing was helping prepare them for that conversation and changing a behavior, or asking them to, be the ones to initiate those conversations. And so we were telling them, you need to discuss what the value that you prioritize. You need to have that discussion. You need to ask questions about how your values are actually impacted by the treatment options that are going to be presented to you. And 3, you need to make sure that you understand how those values are going to be impacted. So make sure that you state in your own words to your clinician how you believe your values will be impacted. Okay. We then conducted another study after we established voice to make sure that it was acceptable, usable, so all the human factors usability type assessments, with a group of 15 older adults that had advanced cancer. We went through the usability testing. We ultimately, after some iterations, found that they perceived it as acceptable and useful in helping prepare older adults for values-based discussions. But the question that becomes, well, that's great, but how do we actually know that anything works in practice? And so we then looked at conducting a study to assess whether or not voice could help prepare these patients during clinical encounters. And so that's where we come to today, which is the pilot testing that we did of voice. I want to walk you through what our objective was. There's several different components of it, and so that's why I said I was going to spend some time going through my methods so that you understand the actual results. So the objective was to estimate the quality of values clarification processes based on a standardized rating scale. So that standardized rating scale, here as you see, it's called vectors. It's values, elicitation, and clarifications of treatment outcomes. And specifically what I was looking at is the quality of values clarification. And I'm going to get into that in more detail in just a second. And it was for participants who either received or did not receive voice. Okay, so some of them were randomized to receive voice. Other ones were randomized to receive an American Cancer Society communication guide. And I'm going to go through the difference between those in just a second. And so that was estimate the quality of values clarification process based on the standard rating scale for participants who did or do not receive voice during different types of consultations that I talk about as being values-based versus non-values-based. Okay, so those are the 3 things, right? I'm going to walk you through each one of those in more detail. So Vectors is a novel rating scale. It was developed specifically to look at the quality of values clarification that occurred during these clinical encounters. It's based on 3 domains. First domain is rapport building, how well the patients and clinicians both engage in rapport. How well do patients engage in these values clarification processes? And how well do clinicians engage in these processes? Now, if you recall, we tailored the summary report in voice to do 3 things. Have patients discuss their values, make sure that they ask questions about their values, and make sure that they understood how their values were impacted. So Vectors is now assessing those particular areas, right? It's discussing 1, how well did both the patients and clinicians gather and discuss information about what matters most to that patient? How well did patients and clinicians both talk about how those values were impacted by the treatment options that were presented? And how well did they have a conversation? Did they get prompted to ask to clarify in their own words how their values were impacted by the different treatment options? And again, they were randomized to either receive voice or the American Cancer Society flyer. In general, there were some similarities between these two particular tools. First, they were both personalized. Both the American Cancer Society flyer suggests that this information was made just for patients with cancer, the same as voice. They both say discussing your values and goals can help you and your provider make decisions based on your preferences, right? So they both were personalized. They both provide lists of questions to help you prepare for that conversation and encourage you to ask those questions. The difference is we provide feedback in voice. The American Cancer Society Communication Guide is helping prepare patients, but it's not providing feedback. We're providing feedback, and we're saying, based on the information we elicited from you, this is what you said was most important. And now, because you said that this was most important, this is the stuff that we think that you should be asking your clinician during this encounter. Right? I also mentioned there were two different types of consultations, right? One we called non-values based and one we called values based. Okay. They both start off with clinicians. In this case, I'll get into more details about who they were. We ran simulated patient-clinician encounters. We trained medical students to portray themselves as oncologists during these consultations. Okay. They engaged in rapport building. So whether or not they were in a non-values based or a values based consultation, they both started off general rapport building, right? Then whichever consultation they were in, they then went through a script, right? And so in a values-based consultation, the script that they were going through was before they talk about what that patient's diagnosis is, before they start talking about treatment options, they take a step back and they say, let's have a conversation about what's most important to you. What are the things that you appreciate doing? What are the things that you enjoy spending time doing? When we think about, what we might be talking about later on, tell me what's most important to you before we actually talk about what treatment options are available. At that point, once they've had that conversation, then they talk about what the diagnosis is. Then they talk about what the treatment options are so that they can then have a conversation. And how are your values actually impacted by the treatment options? And then hopefully the clinician, right, in this case, they're scripted too. So in this case, the clinician is asking, tell me in your own words how you believe your values are impacted, right? So it's values-based. What we hope we would see then is that the treatment recommendation is values-based and ultimately the treatment decision is values-based, right? It's based on what's most important to that patient. Contrary, the non-values-based consultation, the only difference is that clinician's not talking about the patient values. They're just not asking a question about their values, right? They're going through same clinician, right? They're still building rapport. They're still polite, the compassionate, all those things that you want in a clinician. The only difference is they're not actually asking about the patient's values. So they're talking about the diagnoses. They're talking about what they recommend as a treatment option. If the patient does not bring up anything about their values, they're probably going to make a treatment decision. It may or may not be values-based. It could be values-based. It could have actually aligned with the patient's values, even though they weren't discussed. But we're saying, most likely it's probably not aligned with their values, considering we know 50% of current treatment decisions are non-values-based decisions. Now, we also believe that the patient has an option, right? They have agency to bring up their values. So if in fact, during that non-values-based consultation, the patient's like, wait, before I make a decision, let's talk about some things. I want to talk about what's most important to me. What we would hope to see is that the patients who were randomized to receive voice would actually have the agency to do that, right? Because we tailored this information to prepare them for that conversation. And so if they did say, wait, before we make a decision, I want to talk about my values, the clinician is going to start talking about their values. They're scripted to say, oh, okay, let's have a conversation. Tell me what's most important to you. Now, it requires the patient to actually have agency to go through all three of those levels, though. The clinician will keep going back after each of those levels to say, okay, are you ready to make a decision? Until that patient is actually prompted all three of those different levels, right? Now, the third level is the hardest, right? So it's very hard to project information and anticipate what's going to happen, right? But we were prompting them to do so within voice. Okay, so what we would hope to see is that those patients that had agency would actually end up making a treatment decision that was values-based, because now they've gone through that series of those 3 different levels, all right? And the clinician is now talk to them about how they're different, how the different options are impacted by the treatment options that were presented. Okay. So what we did is we brought in, right, we recruited 44 older adults that had advanced cancer to participate in this study. They knew they were going through a mock clinical diagnoses, right? So ethically, we definitely prepared them for the fact that they were going to be doing that. But they were prepared, that they knew that they were coming in for a secondary cancer diagnosis. They knew that they were coming into a mock simulation in which they'd be presented with a secondary cancer diagnosis and asked to make a decision about that. Okay? Most of these older adults, so they were 60 to 88 years of age, most of them had prostate, breast and lung cancer, and we also had several other types of cancer. They had varying levels of education. Most of them were comfortable with technology. We actually had one person who was not comfortable with technology. We helped walk them through that process. Half of them were female. We did not have great representation across races, and I'm more than happy to talk about the reason why we believe that that was the case. And so we did have a good number of individuals going through this simulation. And let me just walk you through what that process looks like for our study design. So again, we were just gathering some basic information about them. They were then randomized to either receive the American Cancer Society Communication Guide or Voice. We then randomized them to go through the simulation. So they were going to go through both simulations, the values-based and the non-values-based, but the order that they did so was randomized. Okay. After they completed the first simulation, we then had our primary and our secondary measures. So our primary was vectors. Remember, that's the tool that is looking at observed quality of values clarification processes for rapport building, clinician engagement, and patient engagement. Our secondary outcomes were option 5, which is observed rating of the quality of shared decision-making that occurred. Collaborate, which is patients' perception of the shared decision-making processes that occurred. And then we conducted semi-structured interviews. And I'm not going to talk too much today about the semi-structured interviews, but again, happy to answer any questions if you do have about that. They were then randomized to go through, or they were then proceeded into the opposite simulation from their first one. And then we again continued to ask those exact same questions and observations. And then lastly, we did one other measure, which is PrEP-DM, which is patients' perception of whether or not the tool, it's the self, so either the American Cancer Society Communication Guide or Voice, help prepare them for decision-making, okay? So looking at this, what we had was 88 total consultations, 44 of them were values-based, 44 of them were non-values-based. When we look at the vectors mean score, so this is out of 100, we see that values-based means are relatively high, right? So again, rapport building, clinician engagement, patient engagement, right? All 3 of those domains total up to between 0 to 100. Definitely we see a difference here in means between values-based and non-values-based, so probably not too surprising. But what we also are looking at here, which I think this is a little bit more telling, if we look at the values-based variability, we actually see very little variability in the values-based when we're looking at those who receive voice. Okay, that's giving me a little indication that maybe there's something there, that voice is helping prepare them for that values-based conversation a little bit better, possibly, than the American Cancer Society flyer, which has a lot more variability. Because remember, it's all 3 of these domains: rapport building, clinician engagement, and patient engagement. The clinicians are scripted to talk about the patient's values. It doesn't mean that the patient's actually going to talk about their values. Okay, so that's just to make that clear. And then when we look at non-values-based, we actually now see more variability in voice than the American Cancer Society flyer. Now, that's making me think, well, maybe in a non-values-based, that patient agency is coming through, and the patients actually are prompting those conversations about their values, which is why we're seeing some more variability, right? When we look at this, I ran some linear regressions. I did control for consultation order and mock diagnosis. And so we do see a clear distinction between the values-based and the non-values-based, but we do see that there's actually a significant difference between the patients who received voice versus those that received the American Cancer Society flyer and Vector's overall mean scores, meaning the quality of the values clarification processes that occurred for those who were randomized to receive the voice tool compared to those who received the American Cancer Society flyer was greater. Okay. When we look at the non-values-based consultations, this requires, again, patient agency for them to talk about their values in order to increase the quality of that conversation, right? The clinician is going to engage with them, but the patient has to be the one to initiate it, right? And so we do see here what looks like a little bit of a difference between whether or not they did or did not. Okay, so let's take that for a second. But we don't really see at this point, when we just look at the means, we don't really see much difference between intervention and control until we actually look at the number of people, right? And so that's why I want to draw your attention to the right-hand side. 48% of the people who received voice actually engaged in patient agency, okay, compared to only 13% of those who were in the intervention. So more of those individuals who received voice were actually able to engage in a values-based conversation. But what's more important here is that when we look at the difference between the values-based, so basically when the clinician initiates the conversation compared to the patient having to have agency to initiate the conversation, when we look at the mean differences here, there's a big difference, right? So voice maybe has a better opportunity to help prepare the patient. We might be able to get better quality conversation, but it's much higher when the clinician actually initiates the conversation, right? And so here we do see a clear difference, and it is statistically significant between a clinician engaged conversation versus relying on the patient to have agency in order to get that conversation to a values-based. I also want to give you some of the results here about the other measures. This is our secondary measures that we used. Again, option 5. This is observed rating of the quality of shared decision-making that occurred between these encounters, okay? We do see what clearly looks like a difference between the values-based and non-values-based. Again, that's not surprising. We actually see very little difference in variability now. And I would like to, this is where I would like to point out that this is solely based on shared decision-making, right? Vectors is looking at values clarification. How well do those patients and clinicians engage in actually talking about their values? And while a lot of, some people say it's the same thing, they are similar constructs, but they are quite distinct from one another. The ability to engage in shared decision-making is actually quite distinct from the patient and clinician engagement in talking about patient values. When we look at collaborate, and we look at, this is, again, the patient's perception of the shared decision-making that occurred during the consultation, we actually don't see a lot of difference here, right? And there's a reason why, okay? So what we see is when we utilize tools like Collaborate, there's actually a ceiling effect. Patients tend to not report very low in Collaborate because they often don't want to offend the physician in how they've rated the consultation. So it's recommended that you actually dichotomize the score between a perfect Collaborate score and a non-perfect Collaborate score. So that's what we did. And if we look at here, it looks like, and then in a values-based consultation between intervention and control, they look relatively similar. However, when we look at non-values-based, we actually see a higher percentage rating a perfect shared decision-making score in the intervention versus the control. And while it's not statistically significant, what is statistically significant is the difference between the ratings of those values-based and non-values-based consultations. So patients perceived those values-based conversations to also contribute to shared decision-making, right? So this is indicated, we ran this logistical regression, again, controlling for consultation order and mock diagnoses, that the Collaborate score, if patients perceived, it was 71% more likely that they were going to perceive the values-based consultation as a higher quality shared decision-making encounter than the non-values-based. And then lastly, we looked at, again, PrepDM, which is the patient's perception of how well either the American Cancer Society flyer or the voice tool help prepare them for decision making. Okay. And so what we do see is that there is statistical significance. So voice was significantly better at preparing patients for the consultation than the American Cancer Society flyer. In fact, as you see, the American Cancer Society flyer even has a lot of zeros in it. Patients couldn't even remember having received the American Cancer Society flyer when we actually got to the consultation part. That's just an interesting fact that they were both given the exact, the mode and mean of delivering either the ACS flyer or a voice were exactly the same. But that was very telling. And so the other thing that we wanted to look at was, again, going back to the notion that we tailored information to that patient. We also, in that process, were prompting them to do very specific things. But one of the other things that we were prompting them to do is bring this information with you to your consultation, because it's going to help prepare you to have that conversation with your clinician. Okay. 52% of the people who were in the voice intervention brought the information with them to the consultation, compared to no one in the control group who brought the intervention with them. Okay. Which actually makes it a lot easier for me to run some of these additional statistics because I can now separate that information. And so we do see that there is statistics that those who brought the tool actually significantly perceived that voice was actually better than having either voice or the ACS flyer. So there was statistical significance there. But going back to the other measures that we were looking at, so again, when we were looking at option 5, it didn't look like there was actually any statistical significance between the intervention and control. But now when we actually break this up between did you bring the tool or not bring the tool, those that actually brought the tool with them, their observed rating of shared decision making was actually significantly higher than it was for those who did not bring the tool with them. So we believe that there is some evidence to support that if you actually can get the patient to bring the information with them to the consultation, there's a chance that they're going to have a higher quality, both values clarification and shared decision-making experience. So overall, and I'm hoping we have plenty of time for questions. Overall, what we really saw was that, and again, this isn't too surprising, but the values clarification processes were higher in values-based consultations, right? That's not terribly surprising, but it does confirm what we were trying to look at. But voice also showed that it was higher quality values clarification processes in both values-based and non-values-based consultations, okay? So again, when we're taking a look at a values-based consultation, so this is clinician initiating the conversation, right? We would expect that anybody who goes into a consultation where the clinician is initiating it, that it would be a higher quality conversation. And it was, but we also saw, right, that the people who received voice beforehand were actually higher even in the values-based consultation than those who received the intervention. So there's two parts here, right? And so we also were looking at, again, the tailoring of health information. Well, how does that actually help us? How does tailoring health information help get those decision support tools into the clinical encounter, right? We believe that tailoring or providing feedback to the patient does actually have a positive impact on these study outcomes, right? We saw 52% of the patients who were told, bring this tool with you. This is going to help you in having a conversation with your clinician. 52% of them brought that tool with them, right? We also saw the significant difference between the people who received voice and were prompted to do those three things. Remember, discuss what they value most. Ask questions, gather information about this information, right? Understand it. Make sure that you can talk about your understanding in your own words about how you believe your values are impacted. We see that tailoring and providing them with that feedback can actually move the needle in that space, right? We know that from this evidence that voice was perceived as useful for preparing them to engage in a values-based and non-values-based consultation, as well as in shared decision-making processes. Okay. Again, both whether or not they were in a values-based or non-values-based. And I think that's all really, really important. But when we have this and we only rely on the tool and we only rely on patient agency to drive the conversation, we're missing something, right? I think the biggest finding from this work is that when clinicians are the one that actually initiate the conversation and we pair it with something like voice, we actually end up with the highest quality of all of the conversations, right? So we can't just rely on the clinician. We can't just rely on the patient engagement. We need to do it all together, right? And so when I think about where are the next steps with this research, right? We know that decision support tools can support these conversations, right? We know that patient-clinician discordance happens. We know all of these things. We have plenty of evidence to support all of this. What we don't have evidence for is how do we actually successfully implement this into clinical practice, right? And so that's the bigger challenge. And we look at, well, what are the facilitators and barriers to actually being able to do that? And when we do achieve that, what we're really achieving is the ability to reduce the amount of treatment burden that patients are going through and improving their quality of life. Because if we go back to the very original part about what the problem is, when patients and clinicians have discordance about what they value most, right, we decrease their quality of life because they end up in the hospital more frequently, right? They end up with more experience of a treatment burden. There's so many more negative things that come out of patients and clinicians not talking about patient values. So if we can bring that value-based conversation into that clinical encounter across the entire care continuum, not at just one point, right? These patients are making decisions at multiple points along their care journey. If we continue to have their values incorporated into that treatment process, I truly believe that we can improve overall patients' quality of life and decrease the amount of treatment burden they have. So thank you very much, and I look forward to taking any questions.
So let's,
Am I going to move out of the way now?
you just stay where you are.
Oh, I stay where I am. Okay.
Would. All right. I'm going to throw it open to questions first here in the room. If anybody has anything they would like to share. Okay.
First off, I think this is such important work. So thank you. I love that you called it voice, like giving them a voice in the treatment process. I had a couple quick questions. So how many sessions did the providers and patients have together? Was it just the one interaction and then you tried like one values-based and one non-values-based? They didn't like meet ahead of time?
They did not meet ahead of time.
It was just
No.
one of each
They
type?
did not know each other.
Okay.
Actually, I'm going to answer that question, but I'm going to add to it a bit, because having that patient advisory group to lead a lot of this work, remember I mentioned that at the very beginning, we had them run through the simulation to see what is this actually going to look like and feel like for patients who are participating in this study. And that was really critical because they changed some of the study design. They said, you need to make sure you debrief these patients after you go through this. Even though you know you've prepared them, that they're coming into a mock consultation, you need to debrief them. Because I just went through this and I'm now wondering, do I have a secondary cancer diagnosis, right? There were other changes that we had to make too. But no, we did not introduce them to the clinician. And again, the clinician was a medical student trained to portray the oncologist. But so they came in, I prepared them again, going through all the things. Remember, you're in a study, you can withdraw at any time, even literally in the 5 minutes into this consultation. If you want to stop, just stop. And then the clinician would come in and introduce themselves as if they were actually the oncologist coming in and introducing themselves for the very first time. And so that they would go through that cycle. And so whether or not they were in non-values based or values based first, they would then get the break. I would debrief them. We would go through all the series of questions that we had for them. And then they would go through the second simulation. So it was a one-day event for the patient to come in. But then we only had 5 medical students. So each medical student did 8 or 9 different simulations. Well, 18 or so 2 each.
So they weren't quite related, but I guess it made me wonder, half of the patients who were told to bring this tool in with them didn't.
Mhm.
Was there any follow-up questioning about why they didn't or what contributed?
Yeah, so in our semi-structured interview, we did ask that question. And it's interesting because pretty much those 52% that said they did said, you told me to, and that at the bottom it said, make sure that you bring this to your consultation. So I did. I mean, just plain as day, it said it. They're rule followers, you know? So maybe if you're a rule follower, you follow the rules. And I did actually have a couple that contacted me and it said, this says I should print it out and bring it with me, but I don't have a printer. Can you print it for me? So they actually contacted me to see that I could actually print it for them. Yeah, but literally nobody who received the American Cancer Society flyer even thought, I mean, it didn't say to print it, right?
Well, I guess I just wonder if it reflects on the usefulness of it to some extent. So if you had mentioned something about personality in the characteristics, I'm like, is it
yeah,
rule
personality.
followers bring it, or are they bringing it because it's a useful tool?
Yes,
make
and
sense?
so exactly, and so and to your point about personality, we did actually assess different levels of personality too. I don't have the statistical power to be able to actually look at any groupings by personality, but it is an interesting factor to consider. Yes, in the interviews, the majority of people had indicated how helpful voice was in helping them self-reflect on what was most important, that they hadn't actually considered some of those things, especially when we start talking about that distinction between living longer versus quality of life, right? And so, I mean, it's clear that voice does help patients self-reflect, which is an important thing. Now, there's a lot of other factors that go into that too, like where's the right time for them to self-reflect, who should they be with when they're thinking about these different things? Do they need someone with them or not? It's an emotional process. So in some of our other studies, it really brought up a lot of emotions to even go through that tool.
We have a question in the chat. Do you think this would make a difference through the cancer journey beyond the traditional? How might you measure that difference?
Yeah, that's a great question about measuring the difference. So yes, I do not believe that this is a point in time. This is not just for initial diagnoses. As a matter of fact, I ask when we do interviews with patients, how often would you want to do this? When would you want to do this? And so for some, it is on a regular occurrence. For others, they say, when I think there might be a change coming in my treatment. And others are very confident. So I think it's roughly about 20% of people who say that they're overall confident in their values, that they don't need anything like this. They already know what they value most, so they're comfortable with proceeding how they feel. And the majority of people say no, that this tool is helpful, but the frequency varies across individuals. But that's an interesting thing. What we look at is whether or not their preferences change over time. So we actually have a study that's going on to see, are their preferences changing over time, which is a really important thing because preferences and the values are not static, right? Especially as you're going through a cancer journey. Matter of fact, I often hear patients say, well, you get on the chemo bus and it's really hard to get off, right? Well, maybe there's an opportunity there. We should maybe be looking at their values more frequently, having those conversations, not just at a point in time, but as a continuous process.
Do you, sorry. I'm trying to do too many things at once, but as I recall, you mentioned that there were families involved a little bit at one point, but I'm thinking that this is an approach that would not just involve the patient, but the significant people to the patient and their families, friends, who are inevitably involved with their cancer care.
Yeah.
So you would what are your thoughts there?
I am a firm believer and proponent of family caregivers being a part of these conversations, a part of the research, both within the development of the things that we're working on, but also when it's appropriate, being involved in those decisions, right? I mean, they're a key part of that dynamic. And so we have some of the previous work that we've done was actually looking at those dyads between the patient and their family member. And it's really interesting to hear this different types of things that come out of that. So I think things that have surprised me the most is when I've been working with somebody and they'll say, if my spouse was present, I would actually have a different answer for you on my values. And that usually means that they would, if their spouse was there, they would say living longer was most important to them. But when they are answering it by themselves, they're not saying that. And to that point too, in this research also indicates that patients tend to apologize when living longer isn't their top preference. And they'll say, I don't want you to think I'm suicidal. I don't want you to think I'm depressed when I tell you that living longer is not most important to me. Because it's not that living as long as possible is not important. It's that they want to have quality of life. It's not about, yes, please keep me alive, but you know, I can't do the things that I want to do, right? They're looking at my quality of life. Now, there are certainly individuals who are wanting to live as long as possible, despite what may impact their quality of life. But so this is where this type of research isn't very straightforward, right? There's so much complexity to talking about patient values and what does that actually mean? And so that's why I believe that there's a lot of, that's why this data-driven evidence is so important when we're talking about how do we actually incorporate these types of processes into decision making.
I feel like I'm adding research for you, so apologies in advance. I'm curious, so I had a similar thought to the one about beyond the initial appointment.
Mhm.
And I was wondering if this might generalize in some ways, you know, like, honestly, I wish patients all got this education at the beginning of any journey in healthcare, rather than just hoping the clinician asks the right questions the right way.
Yeah.
But for those who went through the training, did it help empower them in other healthcare settings? You know, is this something where now when they're meeting with their urologist or, you know, like some other care provider, they feel like they've reflected and have more confidence and ability to have better outcomes in those settings as well?
Yeah, I mean, that's a great point. I don't have the answer to that question. What I can tell you is that, you know, even in our simulation, the people would, not everyone, but, you know, some of the people would say that I'm taking this with me to my next appointment with my oncologist. I'm like, that's great. I mean, to me, that's evidence to support, you know, they do find value in the tool itself. So yeah, I think that's an important thing to be asking. When I certainly, you know, following up with patients, maybe not particularly with this, but just in general, following up with them to ask those types of questions would be really valuable.
Another from the chat, are you aware of any value assessments being implemented upstream within patient portals? Do you think it would be effective in prompting those conversations?
Yeah, so, I mean, I'm aware of other values clarification tools that have been used in studies. I'm not aware of ones that are actually, I mean, we do have studies also going on utilizing this and similar tools for adults with hematologic malignancies as well. But I'm not aware of any other tools that are using this actually for clinical practice. And so I think, again, that leads to the challenge of, even if it's implemented into clinical practice, there's barriers to that process. Mm-hmm.
So this study is just studies, not in a real hospital or for a group of clinic. So how do you see to implement this service for patients? Maybe for a group of physicians or a group of hospitals like UNC hospitals. How can it affect the hospital actually as they just think about money and how we are going to invest time and effort in this. How can you persuade them to do this? This
So I love that question. So I have two answers for you on that. One is, we should be doing this because it's the right thing to do for patients, right? So that's my first answer on that. The second one is, yes, can we look at what the return on investment is for these patients and the clinicians in the hospital? I believe, and there's actually research that supports that when clinicians engage in these types of values-based, compassionate types of conversations, their well-being actually goes up. And when we talk about a time when clinicians are experiencing increased levels of burnout, finding opportunities for them to reduce that burnout and improve their well-being, that's a return on investment. It costs the healthcare institutions a lot of money when clinicians are burned out, right? For many different varying reasons. But we have the evidence. As a matter of fact, this evidence goes back to the 70s about how well clinician well-being improves when they have conversations with their patients about the things that are most important to that patient. But having it actually happen in practice is different. And there's a lot of research that indicates the reason why, right? You put like this box around yourself to protect yourself from all the emotional burden that you think you're about to carry by engaging in this type of conversation. But actually, there hasn't been a lot of research that shows that that's true, right? There's research that shows that's what they do, but not research to show that, in fact, that actually helps them. There's opposite. There actually is research that shows the opposite, that says, in fact, when they open up themselves to that conversation, their well-being is improved. So that's the return on investment that I see.
My question is, I was gonna ask if like study, when you had the med students, did you train them on the value-based questions? And did you ask them how they felt about how effective that was?
Yeah. So we did train them. We actually, Dr. Daniel Richardson is one of the oncologists that I work with. So he spent time helping develop the scripts, training them. We then went through series, I think about 6+ hours of them going through additional training where they actually practiced the simulations to make sure that they understood, one, what does it mean to do a values-based consultation? And so they did get the training on that. And yes, we actually have another study where we actually assessing their perceptions of going through this. And by far they appreciated going through a values-based. Matter of fact, I debriefed them after their simulations to say, okay, what was it like? And there was a lot of like, those non-values-based, even though it's just like a general consultation, does not feel very good. Knowing that I can do this values-based consultation and actually have these conversations with these patients.
We have sort of a related question in the chat. Thinking about clinician burnout, did you look at conversation duration to see if voice made the conversation longer or quicker?
Yep. So we do have that data. There is not a significant difference between the length of those conversations. And some of them, some clinicians actually just have shorter. And so I had 5, there was 5 medical students in general. Some of the 5 just are shorter conversationalists than others. So there's differences between that, but no, there's no differences. Now, there are times when the patient themselves just has very lengthy conversation. And so, yeah, that is one of the concerns that clinicians do have. If I prompt that question, I've now opened up a dialogue that I don't know how to stop, and I end up with somebody who is very wordy, right? That is a concern, right? I believe that goes back to clinician training, that, there's ways to kind of open up the door and have those conversations, right? But we all know that there's potential time constraints, right? That's an issue that we need to be cognizant of.
Regarding like the participants' demographic information, do you know what stage cancer like participants were in?
Yeah. They were all stage 4, or their cancer had metastasized to another organ. So yes, I just saw everybody's eyes get like big and wide. I will tell you, when I started working with this patient population, that's what I look like as well. And then I started working with this patient population and realized, you know what? The biggest thing that I also hear from this patient population is, when I walk down the street, I don't want somebody to even know that I have cancer. And if you did actually see them walking down the street, you would not know that they have cancer. Does that mean that they're, got a lot of things going on? 100%. I was extremely grateful that they were willing to give their time to participate in this study. They certainly didn't need to. They were compensated, which is important, but they did not need to spend their time doing the study. Most of them thanked us for doing the work, that they thought it was really important that we were trying to make improvements in that space.
My other question was to say, since you're doing the study, are you working like generalizing it to trains that students like everywhere maybe?
So Emily Hamburger happens to be one of the residents at UNC who's looking at that part of the study. I'm hoping that that is an area that she's interested in pursuing further. I do think so. LCME, which is the requirements that medical schools are under, recommends these types of conversations, but they're not actually in the medical school curriculum. And so, yes, I would love to see. That's not true. They will have like a session on how do you have a conversation or communicate, with the patient. There's not training on how to actually do that. Yes, I would love to see this type of training incorporated, starting from med school and then all the way up so that clinicians can get CME credit for it as well.
So we just have a couple minutes left, kind of following on a couple questions here. For you and this research, what's next?
Well, so, oddly, I am, you look at me, I think I've been doing research forever because it's just my age. I am new to research. I actually recently transitioned my career into research and I just completed my PhD. So I am applying for a career development award and hoping that I can take this research further. The reason why I want to be able to do that is I'm hoping to do more independent research specifically in this area. I will say the reason why is because when you work with older adults and they say, like I said before, they say, thank you for doing this research, you feel like I'm doing the right thing. And there's so much more work. This isn't, when I first started this, I thought, how hard is this? Just ask them what's most important to them. And I realized, well, that's not actually going to just happen. So how do we actually provide the evidence to support why it's important that we do that? How do we provide the evidence that clinicians see that this is important for them to be doing? How do we prepare those patients, right? That's a piece of it. But then we look at the complexity of the healthcare system in of itself. And so how do we then think about, well, all these pieces come together. So my next step in research is to actually figure out how we can actually take a look at more of the ecosystem and figure out where is the right place for voice. How do we make sure that clinicians actually utilize the information that's coming from voice? And how do we make sure that in those processes, we take a look at all of the people that are engaged in the processes themselves, and the tools that we have available to facilitate that, right? With Epic, with AI, with other aspects. And so really looking at how do we take all of that as the whole picture and not just focus on one thing. So not just focus on the tool, not just focus on the training.
Roxanne, thank you very much.
Thank you. This
Thank
was
you in the audience for your great questions. Hopefully we'll see everyone next week.